Hello, everyone. Thank you for joining on this Saturday. We have another one of our management reasoning series where we tackle how we approach common diseases and how we think about them and making management decisions in the hospital for the most part. I appreciate everyone joining. These sessions are meant for everyone to discuss. As you can see, there's no one particular discussant, and we would love if you would participate with us. Which is also greatly appreciated if you could open your camera, like so we can all see each other. That's even more encouraging for us to engage you all in discussion, and it would be helpful for us to it would tell us that you give us the green light to call out for questions and things like that. I'm presenting today with Yasmin, and I had the honor of preparing the case with her. She's the main preparer for the case, and I'll just be in the background helping. Yas, do you want to start with the case?
Of course. Hello, everyone. Well, we're going to start the case with a 50-year-old male presenting to the ER after one episode of hematemesis. I will give you a little bit more of past medical history, meds, and past social history for the sake of the time, okay? So for his past medical history, he has hypertension and chronic kidney disease in 3rd stage. And he reported having a few drinks the night before. For the meds that he's taken is nifedipine 90 milligrams each day, once a day. And for his past social history, there's nothing. He doesn't smoke or use any substance.
Okay. This is the first aliquot. Thank you, Yasmin. I wanted to ask you all, how does this make you feel? Do you feel nervous? Do you feel comfortable? Are you rushing to see this patient? Are you reviewing their chart and going to see them? What are your first thoughts? What do you want to do when you're thinking and going to see this patient? And what are you checking for? And what do you want to think of when you want to do a focused physical exam? I see Marcella felt nervous. Marcella, would you mind sharing what are your thoughts?
Amazing case, and it reminded me when I was I think my final year of medical school, and I was with the resident, and we are going to the rest because like we did everything was a night shift, and then they called and they said there is a patient arriving here with hematemesis. And I remember that the patient was very severe, so I think the first thing would be to look at the vital signs to understand if they are stable or unstable, because that can change a lot if I'm going to advance on the history or if I want to go for the treatment, start fluid. And yeah, so I think that would be the first thing that I would do, and then go for the ABC because the airway could be severe compromised because of the blood.
Yeah, Marcella, I love it. And what you said, you think of their airway, and if they have a risk of aspiration, for example, what other things do you think of that make them unstable?
I think that I would first follow if I think the patient is unstable. So airway, the breathing, then the circulation, and I'll look for the blood pressure, the heart rate. If I think that they lost blood enough to make them unstable, so if they have hypertension, I would start fluids right away. And maybe I already call for the blood bank to start like collecting exams for blood transfusion if necessary. Yeah.
That's actually great, Marce. That's a great way of thought, definitely thinking about what is our patient having. So how do I need to act before I think about diagnosis? As you very well remarked, assess patient's hemodynamic stability and also think check blood pressure, heart rate, mental status, signs of hemorrhagic shock. It's very important to attempt to quantify the amount and the rate of blood loss. We can ask about the frequency of blood loss or hematemesis by asking the patient how many times he has vomit, if he can, and also are they having melena? Ask them, have you noticed dark stools? Are they having frank hematemesis? Have they said, yes, I did vomit a lot of blood, or I just saw some streaks? That can also help us. Yeah, back at you, Youssef. So for the next aliquote, we have this review of systems. For the vitals, temperature is normal, heart rate is 102, blood pressure is 105/55 with a MAP of 72. And he reports dizziness. That's everything they report. For the exam, there is no conjunctiva pallor or jaundice. The cardiac exam, the patient is tachycardic, but there is a normal rhythm and rate. And in his abdomen, we find mild tenderness in upper quadrants. So for anyone now, what is the next best step in management?
Yeah, so we're seeing in the chat, Sarah saying, reassured that the vitals are stable for now, but wanting to get immediate access. I see EGD. What was the blood pressure? The blood pressure was 105/55. How does the blood pressure make you feel? Are you reassured that their blood pressure is good? Do you want to, does that make you feel like they're safe for the floor? Or what are you thinking? I see Mario said relative hypotension. Do you want to tell us more if you're able to unmute?
Yes, hi. So the patient has a history of CKD and hypertension, so probably his resting blood pressure is probably around 140, so he's systolic. So he probably has a drop of around 40 of the systolic blood pressure. I wouldn't be reassured with that blood pressure, honestly.
Yeah, thank you, Mario. And what are you thinking of doing next?
So assuming airway is protecting, the patient is able to protect airway, breathing is okay, I would get at least one large bore IV, maybe probably two, and start at least, I don't know, half a liter or a liter of normal saline or lactated ringers, and see how the patient responds to it, and also get the blood bank involved to send a blood type and cross matching for this very likely we'll need to transfuse this patient. So will be my first thought.
Yeah, that's a great thought, Mario. Now, for the next best step of management, we can, as you said, start with IV, and remember to start proton pump inhibitors, because high-dose anti-secretory therapy with an intravenous infusion of a PPI significantly reduces the rate of rebleeding compared with standard treatment in patients with bleeding ulcers. Oral and intravenous PPI therapy also can decrease the length of a hospital stay, rebleeding rate, and the need for blood transfusion in patients with high-risk ulcers treated with endoscopic therapy, as just a little tip. Now, as you said, Mario, placed 2 or more peripheric IV with an 18 gauge or larger. Side note, if I said wrong gauge, please feel free to correct me. And then think fluids or blood. We can call GI to determine. And also, what about DRE? Usually it's not needed if the patient is definitely having bleeding episodes. And well, that would be right now all the teachings. And back at you, Joseph, so you can explain a little bit more about types of IV access.
Thanks. Yes, I was wondering what IV access do you all prefer to have in this patient if you're thinking of resuscitation? Like, for example, do you have a particular size in mind that you're thinking of placing in the patient? I see in the chat someone was saying maybe intraosseous might be preferable for large volumes. Do you all have a framework to think of? Leah, do you want to share your thoughts?
Yeah, for just in general, something that has a big lumen that is gives access fast enough. So just very pragmatic, as big as necessary to give fluids fast. I don't know the sizes because maybe they're different for us. We have some color coded as well. So I can't say more about that.
I love it. I think we're all in agreement that we want a large bore IV to give fluids fast. Would you all want a central access or peripheral access, or does that does that not matter to you? Priyanshu, do you want to share your thoughts?
Yeah, I think right now peripheral access would be much more quicker and easier, and the outcomes would be same. And and we would just possibly avoid all the complications that come with the central line access.
Yeah, I love it. So this part I was really hoping somebody would teach me before I started residency. Is that what's the difference between a central access and a peripheral access, and when would I choose which? So I'm just going to give you a general framework to approaching access in patients to help you think about it, and we can take it from there. So central access essentially means that the line is placed in the internal jugular, the subclavian, or the femoral vein, and sometimes it can go into external jugular, cephalic, or saphenous vein. Essentially, it means that the vein is deeper than the superficial one. Although central sounds cool, that they have a central access, it sounds big. It just means that it's going into a deeper vein. Other thoughts to differentiate. So one thing is, what is the difference between an arterial line and a venous line? Have you all ever used a arterial line, for example, before? Yeah. Noah is saying for BP and ABG. And yeah, exactly. So arterial lines are usually for frequent blood draws or to get an accurate measure of the blood pressure. And then tunneled versus non-tunneled is essentially the difference between a line that goes longer under the skin, that is relatively more permanent and to try to prevent infections. And lastly, there's the gauge of the needle. So I see in the chat, we said it should be 14 to 16 gauge. The gauge is inversely proportional. So essentially, the bigger the gauge, the smaller the needle. And the classical teaching is with GI bleed, for example, you want at least 2 large 18 gauge needles, for example, for quick resuscitation. The formula for flow in this case is Poiseuille's law. Essentially, the flow is the radius to the power 4 over length. And I'm going to share the screen quickly just to show it. Let me. And you can see here in the formula that the flow has the radius to the power 4 over length. That means that the bigger the line is, it's way faster to deliver fluids, and the longer it is, the shorter the flow of fluids. With that in mind, if the central axis is going in the neck all the way to the SVC, versus a peripheral line is just going immediately to a superficial vein, which would you think is faster to deliver fluids? Just to give you a hint, the central line is typically 2 18 gauge diameters and 1 is 16 gauge. So it's basically three lines, while the peripheral, you can pick any gauge you want. It goes from 14 to 18, depending on the size. Yeah, exactly. So this was like my teaching point, is that a central line is just a long peripheral IV, versus a peripheral IV you can change the size. So it really depends on the size. So even if it is an acute situation, you would want something, the quickest line that you can place that is big, essentially. And Priyanshu is saying it would be quicker to put a peripheral line. That's true. So it depends on the time and circumstances, but essentially the peripheral may actually be faster as well, not only to place, but also to deliver fluids if you're putting in a larger line per se. And I'm going to share a table with you after the session is done as to how to think about those, but that's the general approach, is that the size and the length is how you want to think about it. Regarding the color, like Leah was saying, there's a color schema about IVs that is usually standardized across all peripheral IVs. So in general, the 20 gauge is going to be pink, the 18 gauge is going to be green, and the 16 gauge is going to be gray. So this is a way for you to, when you go into the room, before asking anyone, you can just look at the color of the peripheral IV and figure out what axis they have and how big it is. There's a silly mnemonic that I sometimes use. It's basically pink is fine, and it's a 20 gauge. Green means go, and that's 18 gauge. And gray is great, and that's 16 gauge. And that's the largest one, just as like a silly mnemonic for you to keep in the back of your pocket. But that's a way of like going into the room and immediately figuring out, oh, I know what axis exactly they have, and I know whether they're ready or not for me to move on to the next steps.
That's really amazing. I really like this mnemonic. And by the way, stay tuned for our amazing tutorial that Dr. Yusuf always posts on his Twitter. Just a quick like plug in, so you can look at his Twitter and find these amazing mnemonics that I'm sure that are very useful for everyone. Again, I'm sorry, IMG here. And then for the next aliquot, we have the labs. Initial CBC will be white blood cells 10.5, hemoglobin 10.2 with a baseline of 12.5, MCV would be 82, platelets 300, sodium 135, BUN 40, creatinine of 1.7, where the baseline is 1.3. if you need me to repeat them. Well, now the question is, how would you further risk stratify this patient?
Yeah, and by risk stratification, we mean how would you know how quickly do you want to run for a transfusion, for a transfer, or what are we doing right now, or what questions what need like think of. Hans, do you want to share your thoughts?
When I just saw the labs and his HB was kind of in a normal range, it's very slow, but it's not at a point where we need to transfuse, and he is not volume depleted, so there is no dilutional effect to be expected. I think then we could go ahead and try to find a diagnosis. Why does he have hematemesis?
I love it, Hans. And Leah, do you want to share your thoughts?
Yeah, I was wondering whether this would already be the point where you would ask about APTT or INR to kind of find out how at risk for increased bleeding they are. But I'm not sure that's one question I had.
Yeah, excellent. So that's exactly what you would do. So you would try to think of things that would increase their INR. So you might ask the patient, are you taking warfarin? Do you have risk factors for cirrhosis? So instead of phrasing that, you can say, how many drinks do you have per day, for example, or do you have other risk factors for cirrhosis, a history of hepatitis, for example. One thing I'm hoping to change your mind on is the anemia and acute blood loss. So when you lose blood in hemorrhage, you're losing blood that is the same concentration as the blood in your vessels. And if you're losing a fluid that is the same concentration, why would the hemoglobin change? Because if you think about it, the hemoglobin is a concentration. And for example, if I have a cup of coffee and I spill some of it, does the concentration of the fluid in the cup change? So what is the mechanism of anemia? I know it's taking us back to pathophysiology, but this is just like a thought process about this. Yes, Hans, thank you. And basically, the hemoglobin only changes once the fluid shifts from the intravascular space into the vessel. Because if you're just losing the same concentration, it's the concentration of hemoglobin in the blood takes time to change. And so if somebody right now loses 5 liters of blood and you check their hemoglobin, it will be normal because they lost a fluid from the same concentration. And essentially in these scenarios, the amount of blood loss may be more important than the hemoglobin. You might have someone who has hemoglobin is 12, but they just had a significant amount of blood loss and therefore are technically anemic, but the hemoglobin has not reflected it yet. The hemoglobin lags behind the blood loss. And this is where I want you to keep in mind is that in these scenarios, you care a lot about the amount of blood loss. You ask them how much they're bleeding, how many episodes of melon are they having, how many episodes of vomiting are they having, and then the vitals. So are they in shock? Do they need a pressor to keep their blood pressure? There's one study that did the ratio of heart rate to systolic blood pressure. And if the heart rate is equivalent to the systolic blood pressure, if they're almost the same, that tells you that the patient is at high risk toward decompensation. Essentially, if their heart rate is beating very fast, that tells you that they're at risk for decompensation and we want to think quicker. Then hematemesis is generally more worrisome than hematochezia because of how active it typically is. Mario, do you want to tell us about the Glasgow-Blatchford score?
So in GI bleeds, there's a bunch of risk scores you can use. I think there's some like pre-endoscopic and ones you use with endoscopic findings. I think one is a ROCAL score. That's you have to implement endoscopic findings, and there's one I think it's called AIM 65, and the other one is a Glasgow-Blatchford score, which risk stratifies into low risk if you have a zero points, or if you are one or more, you're high risk. And this is high risk of needing early endoscopic interventions and resuscitation. So I actually, this patient has a score of 9. Maybe I'm wrong, but it's at least it's not 0, so it's not low risk. And the other thing I would add is I think if a patient is actively bleeding, so if this patient had at this moment still hematemesis, I would consider that extremely high risk and probably would merit a transfer to the ICU unit to have more strict monitoring.
I love it. Deborah, do you want to tell us about the VUN?
Yeah, I put in the chat that when the BUN is higher than 21, that there's this paper that tell that the patient can have more mortality and can make being like in a very severe upper GI bleeding as we are thinking for this patient. So that would be my thought too.
And do you have any idea about the mechanism? Or Ricardo, you mentioned it too. Do any of you have any idea about how that works?
I think it's for renal hyperfusion. I think so.
Yeah, definitely. So the classical teaching is that the protein that you absorb through blood gets digested in the stomach. And when the protein gets absorbed, it gets broken down into urea and BUN essentially. And that's why only in upper GI bleed you see an increase in BUN. There's more recent studies that propose that could this be secondary to renal hypoperfusion, like Deborah is saying. But this is something that everyone loves to teach, and next time you see a patient with upper GI bleed, mark my words, they're going to ask you why is their BUN high, and they want you to say that the protein is getting digested in the stomach. But you can tell them about the new proposed mechanism that Deborah just mentioned. Okay, so Leah, you said you wanted a PTT. But what other lab test does everybody else want? I ordered the PTT for you. Brahim, do you want to share your thoughts?
Yeah, so I feel the liver panel should always be important. You don't want to delay the diagnosis of this patient. They're probably presenting, in this case, if they had cirrhosis, with something related to their alcohol consumption. But you also don't want to rule out other diagnoses, whether it's autoimmune, idiosyncratic, drug injury, or really anything that could cause liver damage.
Yeah, so we got a repeat hemoglobin as well, cooking, a liver panel. Yeah, so these are in general like the things you want to order. So a PT, a PTT, like you said earlier, a type cross match, which is basically to see if they need blood potentially. What medicine can you think of if a patient has a very elevated BUN and you want to mitigate the risk of bleeding? Sarah, do you want to share your thoughts?
Yeah, from what I recall, it's like if you have a BON of like over 100, you can get platelet dysfunction. So you give desmopressin, which like cleaves von Willebrand factor, something like that, and it just helps mitigate the platelet dysfunction.
I love it. Yeah, exactly. Basically, if you have a very elevated BUN, it is thought that through nitric oxide, there's platelet dysfunction, and desmopressin can help release von Willebrand factor from the blood vessel. So that's something you can think of. And then another question I had for you all is patients with cirrhosis or end-stage cirrhosis might have an elevated INR because of their liver disease and their cirrhosis. How would you evaluate their bleeding risk or clotting risk if they're always going to have a high INR? Yeah, I see in the chat thromboelastography. Excellent. I'm not gonna make you explain what that is because it's very hard to explain. But in general, with liver disease or cirrhosis, you might use prothrombotic and antithrombotic factors, and the INR might be elevated and does not necessarily reflect an increased risk of bleeding. And there's this new measure that we can do called thromboelastography, which is essentially a blood test where the clot is rotated, and there's and based on the rotation and the spin of the clot, it helps you evaluate whether there is a hemostatic problem or a platelet activation issue or a coagulation cascade issue, and it can help you guide your whether you want to give platelets or FFP or cryoglobulins, for example. And the other thing is we can check is fibrinogen. So there's suggested that patients with liver disease have dysfibrinogenemia. And a lot of recent studies have been trying to give fibrinogen in patients with cirrhosis who have bleeding risk. This has not been proven in randomized trials to help, but it's just expert opinion is that if you don't have thromboelastography, you could potentially check the fibrinogen level. And if it is low, you can give them fibrinogen back and potentially help with the bleeding. And this is mostly expert opinion and not proven for like mortality per se. Okay. Yes, do you want to take us through the differential?
Of course, before we go to the next aliquot, what happened to this patient, it is very important to take a step back and think, obviously when our patient is stable, and think what are the most common differential diagnoses in upper GI bleed. The most common are three, and it could be peptic ulcer-disease, esophagogastric varices, and esophagitis. Remember, with peptic ulcer-disease, the most common one would be the peptic is higher than gastric. If I'm wrong, please feel free to correct me. Now, we also have to, before jumping into more rare obscure diagnosis, rule out the posterior epistaxis, because in some patients that have epistaxis, they can swallow blood and then mimic upper GI bleed. Again, we must rule out diagnosis of cirrhosis or aortoenteric fistula, or even recent vasculature procedures, for example. And other rare differential diagnosis can be in three buckets: esophageal, gastric, and small bowel. In esophageal, remember trauma, malar waste, tumor, and black esophagus and cameral lesion. And in gastric, gastritis, tumors again, portal gastropathy, and lesions, vascular lesions or malformations such as dura lesions. And for small bowels would be also AVMs, again, tumors, aortoenteric fistulas, hemophilia, etc. Actually, we have CP Solvers have a really great schema that you can consult. And okay, so remember again, the most common peptic ulcer bleeding, traumatic, tumors, and vascular malformations. Okay, I can see Noah, how do we rule out posterior epistaxis? Normally, I would say physical exam. What do you think, Yusuf?
Yeah, I would think so too. You would see if they're having bleeding in the back of their mouth, for example. You can try to evaluate if they're having actual bleed. And then if you're in doubt, essentially talking to your ENT colleagues at all about that.
Now, the next aliquote before we jump into the endoscopy, our treatment for this patient was to start with IV pantoprazole with a bolus dose of 80 milligrams, followed by a maintenance infusion of 8 milligrams per hour, since a bleeding ulcer was suspected. During the night, moderate amounts of melena were produced regularly, but didn't present any other hematemesis episode. So, should I proceed to the endoscopy? Okay, so an endoscopy was performed and the lesion was localized to the medial wall immediately distal to the duodenal bulb. Diluted epinephrine, 0.1%, was injected in several depots, and hemostasis was gradually achieved. Polidocanol, 1%, and 0.5 milliliters was also injected in each depot to address the assumed focus of bleeding. However, there were no visible lesions in the mucous membrane. What do you think might have happened to our patient? Oh, again, they injected the epinephrine into several depots around the area. They believed that the origin, the source of bleeding was. So, and then they also injected polidocanol, 1%, in each depot to address the assumed focus of bleeding. Okay, Noah has a really interesting thought here, portal gastropathy. Would you like to share your thoughts, Noah?
I'm in the middle of a shopping mall right now, so excuse me for some random noises. But basically, orthodystrophy is when you have increased venous pressure in the gastric mucosa, and this sometimes can cause basically the high blood pressures can cause the blood to move through the gastric mucosa and cause some oozing of blood, which would explain the bleeding.
That's a great, that's actually a great differential diagnosis. Now, what do you think about endoscopy? Yes, actually, we can try to stop the bleeding with endoscopy. And for this patient, I will reveal now what they found during a repeated endoscopy, looking for the source of bleeding, and they found something called dulifoil lesion. And before I bombard you with all of what is there to know about dulifoil lesions, does anybody want to share their thoughts about that diagnosis?
Yeah, I could go on, I guess.
Go ahead,
Okay,
Ibrahim.
so yeah, so it's a developmental vascular malformation. There isn't a known etiology, but then unfortunately, the disease itself, the lesion itself, I should probably say, is difficult to diagnose because the surrounding mucosa can appear normal most of the time. And then the bleed itself can be subacute. And so patients might not present. And so this results in delay in diagnosis.
That's great thoughts, Ibrahim. So for this patient, with dulifoil lesions, it's in up to 70% of the cases, the lesion is discovered after the first gastroscopy. In the remainder of the cases, like in our patient, these repeated gastroscopies will normally be successful. Some patients need more than 2, even 3. Why? Because we have 2 reasons. One, whereas endoscopic ultrasound examination may be a diagnostic tool, in around the 44% of patients, the reason of why the focus of bleeding is not found within the first gastroscopy may either be that it is impaired by a large quantity of blood, and in the remainder, 56%, is because the lesion is situated in a way that when you introduce the endoscope, you cannot find it. Now, you can do repeat gastroscopy, balloon-assisted enteroscopy, capsule enteroscopy, angiography, or even technetium labile erythrocyte scintigraphy. And aside from this, does anybody know if CT or MRI are useful? Would you do a CT? Well, actually, there is little to be gained from radiological diagnosis. So it is basically a very good and well experimented GI or endoscopies that can find these lesions because they can be very, very tricky. What do you think, Youssef?
Thank you, Yas, for that teaching point. And like Yas was saying, although bleeding is, we think of bleeding as we immediately do endoscopy or colonoscopy, a lot of time it is obscure. It is hard to immediately find on the endoscopy. A lot of times it's in the small intestines and it's further away than we can reach with the endoscope. And these are when they're trying to develop new techniques to get further and further. The techniques called push and pull enteroscopy, for example, where you can go further than your initial endoscopic ways to visualize the lesion. And this will be like areas of further research. And a lot of times you will see patients who have bleeding, but it's like they will not be able to be found on endoscopy or colonoscopy. And this is where you revert to things like a pill, for example, camera. And this is like things for patients who are stable, not who are like actively bleeding, and where you resort to a CTA, for example, to visualize the bleed. Brahim, do you want to take us through the teaching points?
Yes, of course. So thank you all. Thank you, Yasmin, and thank you, Yusuf, as well, for the very awesome case that you presented both today. And thank you for everyone who had contributed to the discussion. So this was a case of a patient who had presented to the emergency department with hematemesis. And so our first thought was that we should treat this patient just like any other patient who would present with the bleed. So you should look into their ABCDEs and look into their vitals. Specifically, you need also to look into their blood pressure, their heart rate, their mental status. And then based on that, you could start fluids or blood products. And this should be via 2 large IV boards, 18 gauge or larger. And then you should also ensure cross-matching from very early on in case you actually needed to go on for blood products after the IV fluids. And then you could also give this patient IV PPIs as they have been documented to have decreased bleeding rate, as well as decreased hospitalization. And then you should always try to quantify the amount of bleed that this patient had. And you could ask them very simple questions, including how many times did they vomit, whether or not they had dark stools, and if this was a frank hematemesis or not. And then for the central axis, it might be attributed with complications and delay. So you should usually go for peripheral axis. And then for the approach in general on how you could choose your axis, the difference between central and peripheral is that central is usually for deeper veins. So those could include internal jugular vein, they could include subclavian vein, they could include femoral vein. And then for whether or not you are going to choose arterial versus venous lines, remember that arterial lines are for frequent blood draws. So if you think that this patient might require blood draws within their hospitalization course, you could have an arterial line for them. And then for tunneled versus untunneled lines, the tunneled lines are usually lines that are longer. So they go into the skin and they're longer than the untunneled ones. And then for the gauge, remember that the gauge of the needle is actually inversely proportional to the number. So the smaller the number you're gonna have, the larger your needle is gonna be. And then you should always remember it through the colors. So there's pink, green, as well as gray. Pink is usually 20 gauge, green is 18 gauge, and gray is 16 gauge. And also remember the Poiseuille's relationship, which basically can tell you how much the hemodynamics actually can contribute to the blood flow through the gauge needle. And so the larger the radius you're gonna have, the more flow that you're gonna have, the more resistance, the lower the flow. And the length of the gauge of the needle itself could contribute to resistance. So you should, if you want to have higher flow, you should always look for a smaller gauge needle that is in length. And then you should always have it with as large diameter as you can go. And then also remember that you must have a PT and an APTT for bleeding risk. And it's not only, you shouldn't only look into the PT and APTT, but you should also look into whether or not the patient had been taking warfarin, if they have risk factors for cirrhosis, for example, if they had prior history of hepatitis. And then when looking at the hemoglobin, always remember that hemoglobin changes chronically. So for such a patient who would be presenting acutely to the emergency department, their hemoglobin would probably not change as much. So hemoglobin should not be a marker of blood loss in such a situation. And then always remember to look for vitals and amount of blood loss. And then there's also a study that looked into heart rate and the relationship with systolic blood pressure. And it seems that if it's equal or approaching the systolic blood pressure, the patient is at risk of decompensation. So you need to really think quick. And then hematemesis should be more worrisome than hematochezia because hematochezia usually is much less in blood loss relatively to hematemesis. And then there are risk scores for GI bleed. So there's the Glasgow bleeding score that could tell you how you can go on after you actually score the patient. And then for the BON, if it's greater than 21, this is associated with higher mortality. The reason for that is that because of the bleed, there's increased protein breakdown. And because of this increased protein breakdown, you have higher urea, which is a product of protein breakdown. And then you could always give desmopressin because desmopressin will result in von Willebrand factor release from blood vessels. So it would help in stopping the bleed. And then there's also thermoelastography in patients with liver disease. And this is because these patients would have an elevated INR, so you can't depend on their PT. And then you could also check for fibrinogen in patients with liver disease because they almost always will have this fibrinogenemia. However, you should always keep in mind that this doesn't have a mortality benefit yet. For the differential diagnosis for our patient, I think it was pretty wide. You should always keep in mind trauma, tumor, varicose, bleeding, esophagitis, gastritis, peptic ulcer disease, epistaxis, recent VASC procedures. And then there are also differential diagnoses specific to organs. So the esophagus, the small bowel, and the stomach. Esophagus, look into trauma, so Mallory-Weiss, tumor, black esophagus. For stomach, you should look into tumor, inflammation, and small bowel arteriovascular malformation, as well as tumor. And then for this patient, they were eventually found to have something called Delphi's lesion. The diagnosis is usually only with repeat endoscopy because this lesion is difficult to localize in your first endoscopy, and the bleed itself can also obstruct the lesion itself. So the endoscopist might miss it. And then it can be very tricky. So you can go for other options other than endoscopy. You could try pill camera if the patient is stable, and you could go on for CT angiography if the patient is unstable.
Wow, Rahim, I think everyone is so impressed by these teaching points, like so extensive and detailed, and you caught every moment of this session. Thank you everyone for joining. If you're watching on YouTube, we have these sessions through VMR almost every day. We have a wonderful, wonderful community of people who are curious and want to learn and are doing this essentially for fun because they want to grow as physicians. And you can join us for free, and you can just go to clinicalproblemsolving.com, click on listen and watch, and you can click on VMR, and you can subscribe for emails. Like low pressure, anyone can join, you don't need to prepare. And this is just an environment where a loving community joins every time, and we all want to grow and learn as physicians. Thank you all for joining, and happy Saturday.